With pleasure. Hello, everyone. Glad you found us. Welcome to all of you who have joined us online for this session that is part of the exchange event of the Core Humanitarian Standard Alliance. A special warm welcome, of course, to my three guests this afternoon, Dominic Crowley, Samantha Melis, and Marie-Carmen Vignoles. I'll introduce them further in a minute. Before that, actually, I have some housekeeping to share with you, especially, of course, for those of you who are relatively new to the exchange. For others who already have participated in other sessions, you may be aware of this, but this is an interactive event as such. So you will be able to ask questions primarily through an app that is called Slido. Now, what you need to do is actually open another window where you can go to Slido, sli.do, and then actually, or slido.com, fill in the event code, which is um, Core Humanitarian Standard, or CHS, and then actually you should be able to go to this session. So you can ask questions. It sounds awfully complicated, but I think it will relatively be easy to find your way. This session is also, I should mention that at the beginning, it's recorded. So I hope and I think you should be able to see it later on for those of you who would like to actually to watch it or to share it with your colleagues. So I believe those are the main housekeeping messages. There's also a chat box available, of course, in the Zoom application. And in that sense, I see you're all on mute, so I very much welcome that. Please stay on mute so as to ensure that we don't have any further background noise as such. My name is Ed Shankenberg. I'm the director of HERE Geneva. For those of you who are not familiar with HERE, we're a think tank working on the gap between policy and humanitarian practice. This afternoon, actually, I will be your moderator for this event that particularly will discuss the impact of the COVID-19 pandemic on humanitarian action, and more specifically, of course, on our engagement with affected communities. As I said already, a very warm welcome, particularly, of course, to my three guests this afternoon. Dominic Crowley is the head of emergency response for Concern in Dublin, Ireland. Marie-Carmen Vignoles is actually the emergency manager for the operational center of MSF in Barcelona. And Samantha Melis is a researcher with the Institute of Social Studies in the Netherlands. And Samantha particularly has looked at the impact of the COVID-19 pandemic on complaints mechanisms. Before we come to that, actually, what we'll do during this session is we'll start discussing the impact more generally of the pandemic, particularly on our way of working. So how has this impacted humanitarian response in general? And as the session progresses, we'll actually dive into more in terms of what this has meant for our engagement with affected populations. What we'll do actually is, as I said, I will try to keep an eye on my screen in terms of the questions that you will raise, particularly on the Slido application. And I will make an effort, and you can complain later on if I didn't do that enough in terms of asking your questions, bringing your questions also to the attention of our guests. With that, perhaps actually I could start with you, Marie-Carmen. Obviously, as a global health organization, and one particularly that is focused on providing emergency medical care, this pandemic, of course, has been a very, very significant one. Well, for all of us, but particularly also for MSF. Your way of working, I presume, has also severely been impacted by the pandemic. Obviously, the people you assist have impacted it, but also your way of working. So perhaps you could tell us a little bit more in terms of how this has impacted on MSF's model and your way of working.
Okay, thank you very much, Ed, for having us. First of all, it's definitely a pleasure. Now going to the question, well, very short, definitely our way of working and our model of response to humanitarian crisis, it was directly affected since day one. I mean, as all of us, we know, visas were not granted, flights were not happening, airports were closed, restrictions of as well, population, it had an impact as well in the restrictions of our staff. So this meant a lot to not only to the response to the COVID, but as well to manage to be able to continue with our programs. We support, very well, we support most of the time health structures in a quite remote places, but as well in big cities, different programs from maternity to pediatrics to surgical room to emergency room to etc. So first it was how we had to adapt to make sure and to be able to continue providing healthcare to the patients. It was not only an issue affected MSF staff, but as well, of course, our colleagues, Ministry of Health staff. So we had to adapt our programs in, okay, how many shifts, I mean, seems practical questions, how many shifts are we going to do? How many doctors, nurses, etc. How are we going to ensure that we will be able to provide, response healthcare with not having at the beginning enough material equipment, and with the uncertainties of not being able, maybe some of our colleagues to go physically to be present in the hospital. Well, this was one side. And then the other side is how we were able to support Ministry of Health to respond to the COVID. And this was super challenging. Not having material equipment was an issue, definitely. But as well, it was an issue not being able to, as I said before, to bring international staff to support the structures. I mean, not always we had enough ventilators, not always we had enough people prepared in many of the countries that we work. So this support from international staff was very much needed and essential. But on top of that, it's not only that. I mean, we had many staffs that, constantly when you have staff in the field, they go on holidays, they rest, they come back. So we had staff that they were almost burnout because they were already so many months without holidays, and we were asking them, an extra effort because there was huge needs, to respond at the health facility level and at the community level. So definitely a challenge. It was huge. It had an impact. The COVID restrictions and the pandemic itself, in how we were able to treat. Then we can afterwards to discuss possible, how we managed to overcome this thing. So we managed, for example, to identify administrative tasks, routine tasks that some of our colleagues in the field are able to do every day. So we managed to identify each of these profile, which tasks can be done from somewhere else, from Barcelona, from Kinshasa, from Dakar, from Nairobi, in order to reduce as much as possible the extra things, that sometimes it's a lot of workload for our colleagues. So we identify this. We as well were able to, and we had to prioritize. I mean, we had many other issues ongoing, like the specific dossiers trying to work on things or operational research or other things. And everything was put aside and put on hold to focus to the response of the COVID, and not only the COVID, to ensure other programs, So
Right.
very challenging.
Right. No, I'll certainly want to come back, Marie-Carmen, on your question in terms of how this is changing MSF's way of working. And actually, if this is also has implications for the future in a way. But before doing that, Dominique, could you say a little bit more in terms of what concerns experiences have been so far? I mean, you're obviously an organization less focused on health, but clearly there are also needs in other areas. So could you say a little bit more on that in terms of what you have seen with regards to those needs? Whether it's food security, shelter, and so on. So perhaps you could tell us a little bit more on your experiences.
Yeah, my sense, Ed, was that we were going to talk initially about the impact on the organizations and that we come on and talk a little bit more about the impact on communities and our engagement with them. So maybe if I talk a little bit about the organizational impact initially. I think there are a couple of things that are important. One is the differential impact of COVID. You know, it's had different impacts in the same in neighboring countries. It's had different impacts within countries, and it's very hard to say there's a single model or there's a single way in which it's had an effect. I think it's also important to recognize that there's a lot we still don't know. There's a lot that we're still trying to understand, and we're probably still at a relatively early stage of the response. I'd agree with an awful lot of what Mary-Carmen has said about MSF's experience. Excuse me. But I think there has been a very visible difference between the impact on what we've tended to call our home offices, you know, in Dublin, in London, in different places, and what we've seen in the field. And the impact on our home offices has almost been greater than the impact on our country program offices. And we've all had to change the ways in which we've worked. We've all had to adopt 1,000 different virtual meeting platforms. We've all had to get used to remote working. We've all had to get used to working differently within our teams. And we've lost a lot of the immediate impact and the immediate association we'd have with each other when we'd meet in the office. But it's also brought up a question of, do we actually need to keep big offices in Europe or in the States? Do we close them down? Do we let people work remotely? Do we look at regionalizing posts? Do we look at nationalizing posts? Sorry, my throat is awful. Is it going to change the way we structure ourselves and work as an organization? And I think that's really important. I think in terms of the country programs, we're probably at the second phase of what's probably a series of phases. I'd say for the majority of our country programs, and I know there are differences in places like Yemen and Iraqi Kurdistan where the impact has been massive. The impact has actually been limited and short-lived, you know, accepting all of Mary-Carmen's comments. You know, we had the first 5-6 weeks where there was chaos, confusion, high level of fear, high level of anxiety as to what the pattern of the disease was going to be. And then there was a kind of a normalization where communities accepted this as just another risk. We didn't see the massive spikes of morbidity and mortality. We didn't see hospitals being overloaded. We saw in places like Somalia a short spike in the number of burials that were going on. But beyond that, things seemed to have settled relatively quickly. And there was a very quick transition from sort of lockdown to smart lockdown, or to flex down, as Hugo Slim called them, where there was a recognition of the need to be open, where communities were more afraid of hunger and malnutrition than they were of the potential to catch a disease. But communities are so dependent on hand-to-mouth existence that they had to keep working. And if you lock down, you can't. So a lot of public pressure. So most programs, and talking to country directors over the last couple of weeks, most programs are more or less back to normal. Most programs had limited impact on them in terms of the way we tried to continue delivering them, but we had to make a lot of changes to modalities, and maybe we can come back and talk a little bit about that. Staff movement was a problem. Mary-Carmen has talked about getting staff in. I think we had about 70 staff on UN flights, you know, the WFP air bridge that was set up. But actually movement within countries became more problematic. We could get people to capital cities, but then struggle to get them out to program areas. And then within program areas, what do? You had to reduce the number of people in each vehicle. You were down to 2 people and a driver. Either you have fewer people on the ground or you have more vehicles. There's a significant cost implication. There's a significant engagement with the community implication. And I hope we can come back and talk a little bit about that. But I think basically we're kind of back to some degree of normality, but we've all, I suspect every organization on this call has had staff in the field who've contracted COVID. Thankfully for concern, we've not seen any fatalities, but I do know we've seen fatalities amongst our partner staff. And I think there's a degree of anxiety as to what will come next. I could go on a much more length, Ed, but maybe I'll give you the chance to come back with questions.
We'll certainly come back on what's next. I briefly want to go back to Mary-Carmen, because I wonder if some of what actually, it's interesting to hear your different experiences there. And maybe there's a difference because obviously MSF's focus, particularly public health and concern in that sense, has a broader focus or a different focus. Because actually, Marie-Carmen, going back to you, it sounded like, in fact, the sense of urgency, the sense of emergency, in fact, and particularly the impact on your way of working has been more felt by you and is still felt by MSF more than perhaps concern or than Dominique has expressed it.
Yeah, so I will. Yeah, many thoughts come to my mind when we listen to Dominique. Yes, definitely. I think that we cannot talk about all countries in general because each country had the specificities. But what is true is that what we have seen in our experience is true that the communities, they were very much concerned about after the first 6 weeks, 2 months, instead of COVID, of food, water, the essential commodities in the day-to-day life. But what I would say is that this normalization or this going back to normal had a lot of impact as well. And let me explain. Okay, one thing is that the impact that to other programs the COVID has had. If we put example of malaria prevention, if we put example of people on TB, if we put example of people in HIV/AIDS, if we put example of vaccination, all these programs were severely affected in many countries. And this is what we have seen. In the field, most of our partners, as Dominique said, most of the organizations, they had to call their staffs, they took measures to protect because duty of care and etc. We understand the difficulties, as Dominique very well said, unless you had many staff, you had to respect a lot, like only 2 people in the car. This brought difficulties. Then you have to hire more cars. So when we were in many of the locations that we were, usually there are not a lot of organizations, but during these 2, 3, 4 months still, we saw a lot of people that they were not present. And on parallel, as I said, many of the programs that are very important to avoid future epidemic, future outbreaks, meningitis, measles, Nexiea, etc. We are very much afraid that this can happen. As we speak now, in the Sahel, in several countries, there is a peak of malaria, for example, and this is not only linked to the COVID, of course, but the COVID played a role because the prevention programs were not done, because of the supply system didn't work properly, because. So an impact beyond the COVID, and it's true what Dominique said. Thanks God, they didn't happen in Africa and in many other countries in Middle East or in Latin America, or it happened in Europe. If not, it would have happened in Africa. We were not prepared, not MSF, not many of us, and we would have been really a disaster. But this doesn't mean, that we don't have, as I said, luckily we don't have many deaths, like compared to other countries. Doesn't mean that we fear a lot of the impact. During the COVID, during the next 3-4 months nobody was talking anymore about SGBV, sexual violence. It was not a priority anymore. And still a lot of suffering ongoing. Mental health programs were not anymore the priority, etc., etc.
So, Marie-Carmen, sorry to interrupt, but what does this mean for your prioritization? Because actually now what you are expressing also is, it's not only COVID-19, although it may still sort of dominate the narrative and so on, you particularly point to other needs that didn't go away. In fact, even they have been more hidden, perhaps. There was also a question, in fact, particularly on the slide I asked that. So what does this mean for your decision-making around prioritization? Could you say something more on that?
Yeah, well, what we did, for example, we took a decision. In some countries, we have the luxury of having different sections of MSF. So we discussed among us and we said, okay, which section is going to support the government in the call center, tracing contacts, which one is going to try to set up a COVID center for patients. And another ones, we were concentrated in strengthening the capacity of the healthcare provision in hospital or health centers, because for us it was very important as well that if the numbers of COVID were going to increase, that because everybody was going to concentrate in trying to give response to COVID, a pregnant woman was not going to die because there was not going to be anyone to assist the delivery, no, for example. So for us, it was at the same time that we try our best with very limited capacity to support ministries of health in the fight against COVID, but at the same time, very much focus in key programs, the one that they cause mortality, but as well, for example, in vaccinations, to be able to support Ministry of Health, to try our best to ensure that the health care provision was going to be there. To give an example, epidemic response, vaccination during the COVID, no, for a measles outbreak. Well, yes, it's difficult, but it can be done. So we try to recruit more people, have more cars, have more protection equipment to be able to treat in Burkina Faso, for example, to vaccinate 30,000 kids because there was a measles outbreak during the COVID. So yes, this kind of choices and this kind of prioritization, it was there. But another one, for example, it was very painful for us. You know, we have mobile clinics, no, in many of our locations, really in deep, hard to reach location, no? So programs that they were not considered between brackets essential, like, for example, OPD for diseases that they are not linked to mortality, etc. So we, instead of going once per day to a location, we were going maybe twice per week or one per week. So we had to prioritize, and this was super painful for us. I mean, antenatal care programs, for example, are essential, but if you have to choose, and
Right.
so then in state antenatal care
Right.
programs, you focus at hospital level in emergency
Right.
response.
Dominique, what has this meant for concerns prioritization, and particularly also what is your outlook or your prediction for the future in terms of, obviously these hidden quote unquote needs may come more to the fore now as time goes by. So how are you preparing for that?
Thanks, Ed. Yeah, I think the points about the difference between primary and secondary impacts of COVID is probably the most important aspect of this discussion for us as an organization. I think we talked in my first comments about the primary impact of COVID as a virus. I think the secondary impacts are much more important. And we're seeing some quite interesting things in terms of donor responsiveness, which has been uneven. We're seeing interesting things and them trying to push for the reallocation of resources, pushing more things into COVID-related responses.
On the donors, do you see more flexibility? This is also a question being asked.
Not in an equal way. Some donors have actually been very good in some countries, and the same donors maybe been less sympathetic in other countries. And some donors have been poor and unresponsive, I would say, without naming names. So we had a push to do. So for me, the biggest challenge is it's not going to be the choice of. It's going to be. We're going to see a massive increase in the level of need. That's without doubt. You know, the Gates Foundation, the Gatekeeper report they released the other day, they said development gains had been reversed for 25 years in a 25-week period. And it's obviously difficult to quantify it, but I mean, obviously this is having a massive impact on all of the issues about stabilization, about normalization, about development gains. I mean, everything is going to be affected. It's going to make people more vulnerable in a context in which we're going to see more waves of COVID. The World Bank is saying that between 70 and 100 million people, additional people, are going to be pushed into poverty this year alone as a result of COVID. So the levels of poverty and vulnerability are spiking. If you look what Mike Ryan from the WHO said last week, he said, the WHO's best estimate is that 10% of the world's population have had COVID already, which means 90% of us are still vulnerable. What does that mean for us in the next year, next 18 months? If there's no vaccine, and if there's no, more important than developing a vaccine is making it accessible and having mechanisms for distribution of it. You've got Mark Lowcock's sort of interview with Devex last week, where he was talking about this, I'm paraphrasing, but talking about the consequences of COVID, a loss of employment, a loss of remittances, increasing levels of food insecurity, the number of countries at a level 4, bordering on level 5 in places like Burkina of the IPC. the level of social instability, the level of insecurity that we're going to see from those. And the reality is that we're not really getting very much money coming in. The GHO launched at the end of last year was for the highest level ever. It was just under 30 billion. Then COVID came along and it was an extra 10 billion requested. To date, of that 40 billion, a third of it has come in. If you look at the FTS, it says about 33% has come in. And that's comparing with the 11 trillion that the IMF is saying countries have spent internally. And if you take Mike Ryan's thing that none of us are safe until all of us are safe, if we only look internally, if we only control our spend internally and we don't think about the consequences externally, what's that going to mean and what's that going to look like? So for me, there are a load of questions. I mean, what's the pattern of COVID going to be like for the next 12 to 18 months? We're almost certainly going to see an increase of numbers. The daily rate of infection, even in places where testing is rubbish and unreliable, we're seeing record growth in infection rates. What's going to happen to the level of funding if we slip into global recession? Are we actually going to slip into global depression, which is some of the worst case scenarios? What's the public response going to be? If we can't mobilize funding from the public, if we can't sort of leverage public support to put pressure on the politicians, what's going to happen to the aid budget? We've already seen countries like the UK, was it yesterday or the day before, they announced a further 2 billion cut in the humanitarian aid budget. Where are we going with all of this? What's the level of need going to be for the next 18 months? It's only going to grow. And what decisions are going to be made, Ed? And this is going back to your question. What choices are donors going to make in terms of which countries they will fund, assuming that they keep an aid budget of a sensible level? What pressure are they going to put on us to do certain things? What is going to be lost in that sort of triaging process of absolute acute needs being marginalized in favor of other acute needs? Because the level of funding is not going to meet the level of need. And what's this going to do for social cohesion and social stability? Are we going to see more civil unrest and disorder?
Mary-Carmen, I see you're nodding. One question particularly also asked on Slido is to what degree this has changed perhaps the type of negotiations that you have with governments. I mean, clearly MSF works a lot with ministries of health, but also is also dependent on other ministries, particularly when it comes to access. Do you see more access? Do you see less access? So how is this changing your relations with governments? Is it changing your relations with governments?
It's very country dependent. We had some issues at the beginning of the epidemic, of the pandemic, because there was, when the cases started slowly to appear in Africa, in some countries, we were some of the few organizations that started to say, okay, I have a suspected COVID patient. And then we entered into problems with some ministries and some of it saying, no, this is not a COVID patient. Why you are scaring the population, blah, blah, blah. So the first month, it was very tense, very difficult for us in certain contexts. Then as it became more people, with COVID in many facilities, so well, the situation, it was impossible anymore to hide somehow. So we started to have in many countries as well very good collaboration with Ministry of Health. They were very much aligned with us in the prioritization, let's say, of saving lives, not only COVID, also with other pathologies. The reality of the Ministry of Health have suffered quite a lot is that, I mean, when I was saying before that they don't do any more vaccinations, that important programs are not happening, it's not because they don't want to do it. It's not because Ministry of Health, they are irresponsible. It's because they have as well limited budget. They have limited capacities. They had a lot of staff that they were getting sick as well. So they were confronted with a situation as well, no? So with Ministry of Health, I would say that we managed at the end to have very good interactions with most of them. Regarding access, it was, I wouldn't say that it was linked to COVID. It's more linked to the insecurity and tough context where we work. We talk about the Sahel, Mali, Niger, Burkina, Nigeria. We continue with we follow other ones. No, so it was not regarding. There were not more limitations, I would say, from defense ministry or from other, let's say, linked to COVID, I would say.
Can I then actually perhaps move on, particularly to this question, to what degree this is changing your engagement with, in MSF's case, perhaps patients or affected people? We'll hear a little bit in a moment from Samantha, particularly in terms of her research on how this has impacted, particularly with regards to complaints mechanisms that populations may have. Now, MSF's model particularly is one that is dependent on proximity to the population. The fact that you can no longer perhaps be in direct contact with them, how has this changed your engagement with the people MSF assists?
Yeah, well, to be honest with you, we struggle a lot and we continue to struggle. For us, as you said, one of our pillars, it's proximity. I mean, we believe we have to be where the people is, understanding their concerns, their problems, their needs, and be together with them, because as well, this shows solidarity, no? This shows humanity. This has been, as you can imagine, completely challenged. We wanted to be with these communities, but we had a lot of restrictions. Not imposed, but for example, equipment, protective equipment, we didn't have enough at the beginning. So we had thousands of masks, yes, but we don't have all what we needed to protect as well the community health workers, for example, that we have, people that they work every day in the community. So we instead maybe going every day to the community and to do sensitization and to do the surveillance and we had to pass to do it once per week. So definitely our engagement was very much affected. We try, of course, through mechanisms of having meeting with community leaders, with women representative, but at the end of the day as well, you know, and Samantha will know much better than me, is that in the communities where we work as well, there are power structures, you know, so at the end you end up as well meeting, because you have to limit the number of meetings that you do with the community and the engagement with them through local representatives, with all the pros and cons that this has. So for us, it was very challenging. We still don't have the formula, to be honest with you, how to do engagement remote control. It's something that we don't know how to do it. We don't feel comfortable how to do it. And we don't believe that is the way that we have to do it. But yes, of course, I mean, very much open to ideas. This doesn't mean that engagement is that super good. We do it in MSF. We have many things to improve in engagement with communities in MSF. But to be honest with you, not to be within living with the communities and only resorting to people being in capital or whatever. I mean, no, it's not a model that we work
with.
Well,
you said you're open to ideas. So let's see if the researcher has some ideas for you. Sam, we haven't heard you yet, and I apologize for that. Obviously, and I already referred to that, you have been you've been doing research on the impact of the pandemic on particularly complaints mechanisms that affected communities have at their disposal. Could you say something more on that in terms of your research findings, the countries you have looked at, perhaps the organizations and the mechanisms particularly for people to lodge complaints? Could you say something more on what you have found?
Yes, of course. So this is research by the CHS Alliance and Institute of Social Studies in The Hague. We set out an online survey from May to July this year, and we took into account 80 respondents, and we followed up with a number of interviews, and these were from all over the globe. So it was quite a large geographical spread. And yeah, I mean, the research showed especially that the sudden and extended lockdowns had a great impact on the complaint mechanisms, because the in-person, like Marie also said, the contact was broken. So the usual, and also the usual complaint boxes, which is typical for the complaint mechanisms, they are left unattended or were seen as a risk for COVID spread. So the switch to remote modalities was not easy for the organizations who were not prepared for that, or who are not do not see that as part of their organizational structure.
Right. So that, what does that mean? What are the implications of that? People's wishes or complaints are no longer heard. They're no longer taken into account.
Well, I mean, especially in a normal situation, marginalized groups, or in certain countries at least, they heavily rely on these in-person modalities. So COVID negatively impacted their ability to reach out to the organizations. And it also seems that the number of sensitive complaints and sexual harassment complaints have actually dropped because of this lack of personal contact. And that partly relates also to this trust that people have in this face-to-face modality, and a lack of trust in the confidentiality of remote channels. So to ensure the accessibility of these complaint mechanisms, some organizations were required to actively reach out to these groups and not only rely on the hotlines or the email addresses or the WhatsApp services or the Facebook pages. And therefore, as Marie-Carmen also mentioned, there was a strong reliance on local partners, volunteers, health workers, community leaders, and they actually did continue these in-person modalities to large extents, but they also come with great risks. Power struggles, but also the risk of contagion and how you deal with that. Some of these examples were health workers being involved in home visits, or local CRM committees collecting complaints, or organizations reaching out to community leaders to ask them about the project. But community leaders also are not always leaders of the whole community. So how would you deal with that? Some organizations were actually quite creative. So one of them, for example, they combined a focus group with a remotely managed focus group. So they held it with a limited number of people, but then following the health protocols, but there would also be a direct line by phone or by internet with a focal person of the organization. I thought that was actually quite interesting. So it's a hybrid approach to this. Others were having booths with voice recorders where people could share their feedback in private. And on the one hand, this involvement of local actors provides opportunities to also localize accountability mechanisms and increase the access to complaint mechanisms for certain population groups, also in the long term. But on the other hand, when it concerns sensitive matters, people do not always prefer to share their complaints with someone who is based in the community, also due to these power structures and privacy reasons. And we need to also be careful not to just transfer the health risk to the local partners. And I thought the most important takeaway from this research was obviously, as it always is, preparedness is crucial. But not only for organizations to have these, both the remote means and the in-person modalities ready, but also to decide on which channel is actually most appropriate for each type of situation or crisis in this regard, together with the affected communities. And that is something that is not done when the crisis strikes, but that's something that should be done on a regular basis.
Thanks, Sam. Dominic, anything that Sam said that rings true with you, particularly in terms of finding alternative ways for engaging with affected communities?
Yeah, thanks, Ed. I thought Sam's comments were very, very good. Certainly resonate a lot. This whole thing about, we've tried to drop the complaints boxes. We've tried to move to the greater use of mobile phones. We're seeing about the same number of complaints across countries. We know that we need to do more work on CRMs. I don't think any organization would claim to have cracked it. I think that it's generally regarded as an area where we all need to make improvement. I think the need to adapt in the face of COVID is hugely important. talking to our country director in Somalia this morning, he said the fact that the teams aren't on the ground is a massive loss. The immediacy of contact, the immediacy of engagement, both from our own staff and from our partner staff. I spoke in the last couple of days to our country directors in Pakistan and in Somalia, because they're almost at the polar extremes of the sorts of contexts within which we work. And what I found was, very, very similar types of adaptation. And it was a move towards much more virtual, much more online. I mean, they both talked about having Zoom meetings with village committees or with groups of elders. They talked about having Zoom meetings or WhatsApp chats or all sorts of iterations with the partner organizations with whom they work. But it's all about compensation for the loss of engagement. Somalia program, because they've lost the contact from the passing of messages through the nutrition program, recruited a company to work on the development of short dramas. And those short dramas are all around health messaging about hand washing, breastfeeding, immunization, these sorts of things. And anyone who's in the cash transfer program is phoned, and this dramatization of different actors playing out an issue is played to them. They're about 10 minutes each. And they reckon about 75% of the recipients of the cash transfer program are getting this public awareness messaging. We've engaged with imams. We're using loudspeakers in mosques to broadcast public health messages. We're using imams as point of verification on beneficiary lists. But I really liked the work that the Cash Consortium in Somalia has been doing. So they work with the village development committees, the VDCs, to develop the beneficiary lists. The beneficiary lists are sent back to the organization that do a spot check, a 10% spot check, phoning the people who are on the list, asking them questions around, criteria as to why they've been included. So they do that verification. If there are problems with it, they check with the VDC, and then they check with other people, the elders, teachers, imams, to verify, is this family, should it be on the list? Then they send it to the Cash Consortium, and all the calls that are done from Concern and the other members of the Cash Consortium to intended beneficiaries are routed through a call center, and all the calls are recorded. So when the lists go to the Cash Consortium, they can then verify the lists, the recording, they do spot checking, and only then is the money released. So it's all virtual. The follow-up, the post-distribution monitoring is done by follow-up. It is very disembodied, but there is still some degree of community engagement. Nutrition staff still go out and meet with people, particularly women who don't have access to phones. We reckon in Somalia, 90% of our beneficiary group either have a phone or have access to a phone, and the onus is on us to find ways to push messaging out. The one thing I worry about, Ed, in terms of community engagement and community perception, and it's the same as what we saw with Ebola, is this very Trumpian notion that it's all fake news, that the humanitarian community is using this as a way to generate money, and it's creating a level of antagonism and opposition to programming in some places. And that to me is really worrying. But yeah, the whole modality, the whole way of working, it's become depersonalized, and we've lost a lot from that. But in the context in which we're in, our national partners, our national local partners, and ourselves, we're trying all the time. I think Mary Carmen said there's no easy solution to this yet. And we're trying all the time to come up with ways that do work. So it is the case of testing it and seeing if it works. We need to go back and speak to people. Did you listen to those dramatizations that came over your phone? What did you take from them? What did you learn from them? Have you applied them? Is it actually having an impact as a modality? But yeah, it's an ongoing challenge and process.
Many thanks, Dominic. I think these are very, well, obviously you mentioned a couple of very interesting new experiences, but then particularly also this note, this sort of concerning note, particularly there in terms of, well, what the risks are or the issues are. Mary Carmen, moving to you perhaps, are there particular examples new ways of working perhaps that MSF now is applying to find alternatives, perhaps in terms of the engagement with the communities it works?
Well, to be honest with you, we are coming up in MSF with new ways of working in the sense of, as I said early on, to review the workload of our colleagues and things that are more is less needed, no, that you don't need someone in the middle of Mali to do it, so then to be removed. But to be honest with you, with engagement of the community, we are not looking into models of doing things in a remote manner. I mean, I would kind of challenge in the sense of, I know we have to somehow, at the beginning we had to do it, but now, yes, it's true. I mean, more contacts will happen and etc. And this pandemic will be with among us for the next years to come. But what we are looking more is into adjusting with more protective equipment, with more cars to respect the distance, with but more logistically speaking adaptations to make possible that community engagement. I mean, as soon as the visas, for example, is able to get it, we have more, even if it's possible, more staff in the field and not less, no? So yeah, what we are looking into is that how we can do community engagement better, because we think within the organization that is something, as you know very well, that is, we were not used to do it years ago. So it's something that we recognize that we have to improve a lot. See others what they do. I believe that in the last 20 years we have improved. So now we talk more with the affected population. We ask about the needs. We engage with them. We involve them in the programming, etc. We are looking more into that thing, but not into how we have to do it in a different manner, losing that proximity because of the COVID.
Well, clearly, these are challenges for every humanitarian organization. And I think this is exactly already something that all of you, in fact, have pointed to. We're coming towards the end of this session. I'm sorry it was going to be such a short one, because clearly this is part of a much longer dialogue in that sense, and shamelessly I'm putting here in a plug for our own work, as here we're looking into the implications of the pandemic. What is the impact of the pandemic on our ways of working? So in that sense, I think this dialogue has shown that obviously many of the challenges I just said, in fact, are collective ones, and particularly I think Dominique, you also pointed to a range of particular challenges for the coming period, which again clearly are ones that affect all of us. I would like to thank you at this stage, all of you really, for your involvement and your participation today. Also particularly those, of course, in the audience that have been following this session. Sam, thanks very much for sharing your initial research. Keep that up, because I think it's very important to provide these results, and to show, particularly also to provide examples of perhaps what can be done, so to come up with alternatives. Thanks for that. Thanks again, Dominique and Marie-Carmen, for sharing your experiences in your organizations. Again, as I said, I think this is more the beginning of a discussion than anything else in that sense. Keep up the good work, and I'm sure we'll be further in touch in terms of how we can collectively address these challenges. Thanks again to all of you for attending this session. Thank you to MIT for facilitation, and particularly to the Core Humanitarian Standard Alliance for organizing this exchange event. All the best for the rest of your day. Thank you.
Thank you very much.
Thank you.
Thank you very much for a great session. Just to remind everyone, the closing of today will be starting in around 10 minutes. So if you head back to the virtual platform, you'll find the link for the closing session of today. Thank you very much for all our speakers today. The video will be, or the recording will be uploaded onto the platform shortly. Thank you very much.